Assalamu alaikum doctors, welcome to my YouTube channel MBBS and BDS lectures. Today is the second video of rapid revision course of fixed partial denture prosthodontics, which is very important for NLE, MDS, NBD as well as for BDS students. In this video we will discuss about retainers, which is the part of fixed partial denture. In first video we discuss about different parts, classification of fixed partial denture, its indication and contraindication. In the second video we will discuss one part of fixed partial denture, which is retainer in detail. In this retainer we will discuss definition of retainer, the characteristics or requirement of ideal retainer, then classification of retainers, types of retainers, and its indication, contraindication, advantages and disadvantages, mean everything about retainers. First we start from definition of retainers. What are retainers? We can define the retainer by two ways. Number one is a retainer is defined as any type of device used for stabilization. It's retain the processes used for stabilization or retention of processes. Its name suggests retainer mean it is for retention of processes. This is the first definition. Like here, because an abutment tooth retainer retain the bridge. Second definition, a retainer can be defined as a casting cemented to an abutment teeth which retain or help to retain a pontic. Mean a retainer is a casting which cemented to abutment tooth which retain or help to retain a pontic. Like here, they retain a pontic. This is the second way to define the retainer. Now come to the factor required for ideal retainer. What are the factors which required for ideal retainer? There are 5 factors. Number one is the retention qualities. In retention qualities, retainer should have adequate retention to bear the functional forces. The axial wall of the preparation should be as parallel as possible. Length of the edentulous space. Mean the retention qualities, the factor which required for ideal retainer. First is the retention qualities. Retainer should have adequate retention to bear the functional forces, because the opposite teeth forces will be on retainer which transferred to an abutment. Now, the axial wall of the preparation should be as parallel as possible. Mean when we prepare the abutment, the axial wall should be parallel as possible. Now, the length then which factor which affect the retention of the retainer? These are important for MCQ's point. The length of the edentulous span, type of design and surface area are some of the factors which affect the retention of the retainer. Mean what are the factors which affect the retention of the retainer? The length of the edentulous space, the type of the design of the fixed partial denture, or and surface area of the sum of the factor. These are the factors which affect the retention of retainer. After retention qualities, the second factor is the strength. Adequate strength to resist deformation under functional stresses is an important requirement for ideal retainer. Mean for ideal retainer, the important factor is a strength. Why? To resist deformation under functional stresses. The third factor is a biological factor. In biological factor, per retainer, When we do tooth cutting, there should be conservation of tooth structure and a relation of margins of restoration to the gingival tissues and contour of the restoration. Mean in biological factor, first we should conserve the tooth structure, do not do overcutting, and relation of margin of restoration to the gingival tissue, mean there is no overhang retainer, and contour of restoration, there will be well contour of restoration and well finished and polished. Next is the aesthetic factor. In aesthetic factor, the retainer should be aesthetically pleasing. Mean the retainer should be aesthetic because retainer is a crown. Next is the last factor is the ease of preparation. There should be ease of preparation to make the retainer. Mean there is no difficult steps in formation of retainer. These are the factors required for ideal retainer. Now come to the classification of retainers. We classify retainer on two bases. Number one, on the basis of location, where retainer is retained. On the basis of location, there are three types: class 1, class 2, class 3. Class 1 is extracoronal retainer. When we give a crown, this is extracoronal retainer. Like here, there is a complete crown over abutment teeth. This is extracoronal retainer, which is class 1. Class 2 is the intracoronal retainer. Intracoronal retainer like inlay, onlay. Third is the radicular retainer. These retainer are given in the roots portion. This is classification on the basis of location. Next, classification on the basis of type of material used. Mean in formation, in making of retainer, which type of material we use. There are four types. All ceramic, mean everything is made of ceramic. Second is all metal, mean everything is made of metal. Next is all acrylic, everything is made of acrylic. Second is the metal acrylic, it is a combination of metal and acrylic. Now after classification, come to the selection of retainers. Now when we select the retainer, the selection of retainers depend upon the following factor. Mean when we select extracoronal retainer, when we select intracoronal retainer, mean the selection of retainer depend upon following characteristics. Number one, condition of abutment tooth or teeth or implant. The first factor which affects the selection of retainer is the condition of abutment tooth, teeth or implant. In this, height, mesiodistal width, location, periodontal status, and angulation are some of the factors which greatly influence the selection of type of retainer. Second factor is the functional relation of the adjacent gingival tissue. Mean the relation of retainer with the adjacent gingival tissue, functional relation. The axial contour of the natural tooth, position of the contact area, and nature of the embrasure greatly influence the health of the gingival tissue. Full veneer or complete crown, if we give mean extracoronal retainer, which is the form of full veneer or complete crown, produce the maximum, and mesio-occlusal MOD restoration produce least disturbances to these factor, mean adjacent gingival tissue. Third is the factor is the available interocclusal space. Mean between two arch, the available interocclusal space also affect the selection of retainer. Amount of interocclusal space determine the type of retainer that will be most suitable for the patient. Next factor is the presence and extent of caries. If there is more caries, we give extracoronal retainer. If there is less caries, we give intracoronal retainer. This determines the type of retainer to be selected. Small and shallow caries indicate intracoronal retainer, where large and extensive caries demand the use of extracoronal retainer. Remember, this is MCQ's point. When we give extracoronal retainer and when we give intracoronal retainer. If there is a less caries, small and shallow caries, we give intracoronal retainer. If there is a extensive, large, deep and extensive caries, we use the extracoronal retainer. Next factor which affects the selection of retainer is the material used for pontics. Mean from which material we make pontic, and because the stabilization, the retention of pontic and abutment is the retainer responsibility. Therefore, the selection of retainer depend upon which type of material used for pontics. Next is the morphology of the crown of the abutment. Morphology of the crown of the abutment. To some extent, crown morphology determines the type of retainer used. For example, pig-shaped lateral usually require complete coverage crown. Mean the selection of retainer also determined by morphology of the crown of abutment. Like in pig-shaped lateral, we give complete coverage crown, mean extracoronal retainer. Next is the periodontal condition. The periodontal status of the abutment teeth greatly influences the choice of retainer. More advanced generalized chronic periodontal problem leads to gingival recession, bone loss, and even mobility. Splint or appropriate extracoronal retainer are usually indicated. If there is a periodontal condition, then we give extracoronal retainer. If there is more caries, we give extracoronal retainer. Next is the length of the edentulous space. This will influence the extent of the functional forces transmitted to the retainer. Longer the span, greater will be the stresses and greater will be the need for bulk and strength of retainer to resist torsional forces. If the length of the edentulous span is more, then we make the retainer bulky to resist the torsional forces. Next is the position of the tooth. Partial veneer crown are usually indicated in the anterior region, uterostatic, and full veneer crown are indicated in the posterior region. If we give retainer bridge in anterior region, then in extracoronal retainer we should make partial veneer crowns. But in posterior teeth we give full veneer crown. Next is the occupation, age, and sex of the patient. Selection of appropriate retainer is influenced by this factor as well. For example, younger patients have higher pulp form and therefore have higher chances of pulp damage than older patient. Next come to the types of retainer. There are two types, extracoronal and intracoronal. In extracoronal, then extracoronal we give in the patient which have large and extensive caries and periodontal condition, and in extracoronal retainer we give crown which is partial veneer crown or full veneer crown. Simple. Extracoronal retainer also known as major retainer. Extracoronal, the first type is the extracoronal retainer. Extracoronal retainer are cast metal restoration or crown that encircle all or part of the remaining tooth structure. More tooth structure is removed in extracoronal retainer to provide adequate bulk. Therefore, adequate bulk per strength than intracoronal retainer. These retainer, extracoronal retainer, are also sometimes referred as a major retainer because here they cover the more surface of the tooth, and the more carious tooth is removed and filled, these teeth is a bulk material. Now, in types of extracoronal retainer, there are two types of extracoronal retainer which are full veneer crown. Second is the partial veneer crown. Next come to the full veneer crown, encircle the tooth completely, and partial veneer crown in partial manner. Next come to the intracoronal retainer. How we define intracoronal retainer? Intracoronal retainers are defined as within confines of the cusp and normal or axial contour of the tooth. Mean intracoronal retainer are confined, mean they are confined to the within the cusp and normal or axial contour of the tooth. Mean they confined to the axial contour and cusp of the tooth. Intracoronal retainer lie within the normal contour of the clinical crown of the tooth. Now come to the types of intracoronal retainers. In intracoronal retainers, there are two types. One is the proximo-occlusal inlay, second is the mesio-occlusal distal onlay. One is the inlay, one is the onlay. One is the proximo-occlusal inlay and second is the mesio-occlusal distal onlay. First is the proximo-occlusal inlay. In figure 22.2 is the proximo-occlusal inlay. How we define proximo-occlusal inlay is defined as a fixed intracoronal restoration, a dental restoration made outside a tooth to correspond to the form of the prepared cavity, which is then luted onto the tooth. Mean they are formed outside the tooth in the lab and they are luted onto the tooth structure. This is the proximo-occlusal inlay. And the next thing is the difference between inlay and onlay is that inlay do not cover the inlay do not cover all the cusps, but onlay cover all the cusps. Now, what are the indications of proximo-occlusal inlay? In indications, if there is a minimal caries or old restoration that required a mesio-occlusal or disto-occlusal restoration, mean minimal caries or old restoration that required a mesio-occlusal or disto-occlusal restoration, this is the first indication. Second is the if there is adequate dental support, again we give inlay. Third, if there is a low caries rate, again we give inlay, intracoronal retainer. Next is the patient request for all ceramic or gold restoration instead of amalgam or composite. If patient do not willing for restoration of amalgam or composite and patient require all ceramic or gold restoration, then we give for inlay. Now come to the contraindication. Contraindication will be opposite of this indication. Like the indication of inlay, proximo-occlusal inlay is if there is a minimal caries, low caries rate, adequate dental support. Now contraindication will be opposite, high caries rate, high caries mean inadequate dental support, poor oral hygiene. Now in contraindication is the if there is a high caries index patient, poor oral hygiene, youngest adolescent patient, there will be exposure of the pulp due to long pulp and long pulp horn. Next is the parafunctional habits such as bruxism. In the result, there will be fracture of restoration. Next, next is the mesio-occlusal distal inlay when we give increase the risk of the fracture. And next is if teeth is small, again this contraindicated mean inadequate support. Next, if is a poor dental support requiring extensive preparation, if they require extensive preparation and poor dental support. If adequate dental support, then we give inlay. If pure dental support and extensive tooth preparation, then there will be contraindicated. What are the advantages and disadvantages of the proximo-occlusal inlay. In advantages, there is a superior material properties because here we use all ceramic or all gold. There will be superior material properties. Next is the longevity due to superior material properties. Next, no discoloration from corrosion, again because we use whole material like all ceramic or gold restoration. Next, least complex cast restoration, and because it do not cover all cast and less wear in comparison to composite. In comparison to composite, they have less wear. Next, what are the disadvantages? Less conservative. The disadvantages is the less conservative than amalgam. Because amalgam restoration is conservative, here they are less conservative. Next is the display of metal. Because next is the display of metal. This is disadvantages. Then next, inlay utilize wedge type retention which exerts some outward pressure on the tooth. Next, it is a time consuming because they are indirect restoration to make in the lab. Next, it is costly, and next is the accurate occlusion is difficult to achieve. Next is the intraoral adjustment is difficult as it fragile before bonding. Any adjustment require careful finishing and polishing, which is time consuming. These are the disadvantages, mean costly, time consuming, display of metal, less conservative than amalgam, occlusion is difficult. Now come to the MOD, mesio-occlusal distal onlay. Mesio-occlusal distal onlay is a restoration that restore one or more cusp and adjoining occlusal surface or the entire occlusal surface. Mean here the all cusp is involved of the occlusal surface. It is retained by mechanical or adhesive bead. Here in diagram 22.3, MOD onlay are maxillary first premolar. Now, what are the indications? If there is a worn or carious tooth with intact buccal and lingual cusp, if buccal and lingual cusp are intact, but there is a carious tooth, worn tooth, then on that cusp we give mesio-occlusal and distal onlay, because this onlay mean above the cusp, and this cusp will support the restoration. Next indication is the MOD amalgam requiring replacement. If any patient have mesio-occlusal distal onlay of amalgam and they require replacement, then we replace it. Next, MOD restoration with wide isthmus. If there is a MOD restoration and the isthmus is the area between cusp, from one side cusp to other side cusp, if there is a wide isthmus. Next, if there is a low caries rate, because in high caries rate we give extracoronal retainer. Now, after indication, what are the contraindication? If there is a high caries rate, patient with a poor oral hygiene, short clinical crown. These are the contraindication. What are the advantages? It provides support for cusp. It has high strength. It has longevity. What are the disadvantages? It does not have adequate retention. It is less conservative than amalgam because here we remove more tooth structure. Castable glass ceramic is less abrasion resistance than traditional feldspathic ceramic, because here they are found from castable glass ceramic. And resin flesh or overhang are difficult to detect and clean, which ultimately may lead to periodontal problem. Mean here the overhang are difficult. Finishing of the margin is difficult in less accessible area. Now, this is all about retainers, its types, requirements, classification, and in types there are subtypes, its advantages, disadvantages, mean everything we cover about retainer. Now, in next video we will discuss the next parts of fix partial denture in detail. Now, if you like my video, press the like button and share this video with your friends. If you're new to my channel, subscribe my channel by pressing the red subscribe button and also press the bell icon in order to receive my each new video notification. For watching my videos, I am very thankful to you. Thank you very much.